Hello and welcome to our inaugural edition of Monday Special Town Hall, coming to you live from the Tomboya Labour College here in Kisumu County, a critical county, as we'll see in the next hour or so in this discussion about universal health care, universal health coverage, some people call it. And here tonight we are going to have a discussion with different people, and this is a discussion we'll have every Monday night, focusing on different ideas, different items, but all focusing on the big four agenda that is a national government agenda but is being cascaded to the counties. And tonight on my panel here, I have the governor of this county, Professor Anyang' Nyong'o. Karibu sana. I was making a joke that I was with you here not too long ago when we had the gubernatorial debate, and here you are as the governor of Kisumu County. Welcome to our show tonight.
Thank you, Joe. I told you so then, eh?
Yes. Professor Nyong'o is also a former Minister for Medical Services, and we'll be talking more about that. Dr. Jonah Manjari is the CEO of Kenya Medical Supplies Authority, KEMSA. Karibu sana to our discussion. We also have with us Esther Achieng' Okech, who is the Executive Director and Programs Coordinator for Kenya Female Advisory Organization, a grassroots organization called Kefiado, which is going to bring a community voice into this discussion. And last but not least, Dr. Dickens Onyango, who is the Director of Health here in the county of Kisumu. Karibu sana, Daktari.
Thank you.
We also have an audience here. My colleague Mashirima Kapombe is somewhere in the audience, and she'll be engaging the wonderful ladies and gentlemen in this room to get some perspective from the floor. Kapombe.
Joe, how prepared is Kisumu? Is the supply of drugs and medical equipment sufficient? Well, the audience here is ready to put to task their governor and KEMSA on that very important agenda of universal health coverage. But first, earlier today, I was at the Jaramogi Oginga Odinga Teaching and Referral Hospital, and this is how the situation is. We apologize. It seems we have a technical hitch. We'll bring you the story later on in this production. But first, Joe Ageo, continue.
All right, thank you very much, Kapombe. We'll definitely be getting back to those sentiments from the people on the ground. But most of the issues still revolve, and Professor Nyong'o, I will start with you here. Most of the issues still revolve around very many basic things, whether it is a question of how long people wait at clinics, whether it is the issue of drugs and so on. Where are we in this journey that we are talking about, that we want to make sure that everybody has access to health services? After all, Article 43 of the Constitution actually guarantees right to health, the highest attainable level of health. That's what the Constitution calls it.
Well, Joe, the aim behind universal healthcare really is to meet Article 43 of the Constitution. And that assumes that the health system is working as it was designed. Mind you, we have a 5 kind of tier health system. You begin from the primary healthcare in the dispensary, and then you go to the health center, then you go to sub-district hospital, then you go to district or county hospital, then you go to referral hospital, which is Jaramogi Oginga Odinga Teaching and Referral Hospital in the case of Kisumu County. But there's also level 6, which is Kenyatta National Hospital, which is a national referral hospital, and we also take Moi Teaching and Referral Hospital these days as level 6. Now, it is assumed that when somebody has a basic ailment like a wound, you will go to a dispensary. You will not necessarily rush to Jaramogi Oginga Odinga in Kisumu or go to Kombewa at sub-district hospital, but you go to the primary health care, which is a dispensary. And if you're not really satisfied, you should go to the health center. But that is not how things have been working in Kenya. The referral system has been dysfunctional. And so you find that a hospital like Jaramogi Oginga Odinga is inundated by people who should not be there. People should have been taken care of by the lower down health facilities So Jaramogi can act as a real referral facility. So you go to Jaramogi, and they are full with people who should not be there. Some should be there, but most of them should not be there. And that is why there's constant complaint that we can't get services from Jaramogi, because you are not going to the place where you should be getting services anyway. So universal healthcare that we are introducing is going first and foremost to streamline this system. But another thing that universal healthcare is going to do is to make sure that when you go to the primary healthcare, which is a dispensary, you have that facility functioning to the optimum. It is the medicine required, the human resources requires, and the infrastructure necessary. One of the reasons why I brought the Cuban doctors here is because in Cuba this same system works. In Cuba, it begins with a family level. And in this particular county, right from the beginning, even before the national government came with universal health care, we had already decided in my manifesto that we are going to pay community health workers.
And I will talk about Kisumu County later on in this show, but Dr. Manjari, part of this universal health care, when everything is working the way it's supposed to be, we have the question of medical supplies. First of all, what is that in the first place, medical supplies, and how does that fit into the whole conversation of UHC, as it is called in those circles?
Yes, thank you very much, Joe. When you look at KEMSA, which is a corporate established through an act of parliament, our mandate is very clear, where we say we are doing procurement of essential medical supplies and other commodities. We are doing warehousing, and we are doing distribution. Then when it comes now to what the question you've asked, what is the medical supplies? It's everything the patient needs when they go to see a doctor. When a patient goes and walks in a room where they have gone to see a doctor, they will expect that a triage will be done, where the BP will be taken, height will be taken, the weight will be taken, and immediately that is done, the doctor will take a history. After history is taken, the doctor will form an opinion and will either send the patient to a laboratory and or send the patient to the pharmacy. So all those issues that are surrounding the way the patient is taken care of is essentially what is the medical supplies. And when you look at it, KEMSA role in this is that we have committed ourselves that will give the counties that are under the pilot 100% order fill rate. What it means is that whatever they will order from us, will be able to deliver to them timely, of high standard, issues that are of good quality, accessible. And
how does that deal with what a lot of people say, nimeenda huko na hakuna madawa? Because that's a very common thing that you hear from people, like, oh yeah, there is no medicine in all these.
Yeah, that question can really be answered on what we call the prioritization of the people who are doing that. When you talk to many of the doctors, and I've been a doctor in many facilities in this country, it is not a question of hakuna madawa. It is a question of kama hizo dawa zimenunuliwa. And the person who is responsible is either the government or the hospital management or the person who is manning a clinic, whether they have done an order. You find that when people do order, there are several types of medical supplies. There is what is called essential, that must have. There is what we call the specialized, that when you, what Professor was saying, when your condition is not what is the normal, then it will be maybe a specialized commodity, like what we'll have if you go to Kombewa District Hospital or dispensary, and you find that they have renal products, then that is not prioritization, because those products will not be in that facility. So really, we have to reorganize ourselves, and we have to focus on what is, we are saying prioritization. And KEMSA comes in because we have the knowledge to do quantification and forecasting and guide the county pharmacies and commodity nurses to really stock what is really required.
Prioritization. Dr. Onyango, if we come to you, what's that about? I mean, I was looking at a report by the Kenya National Commission on Human Rights, specifically about Kisumu County, and some of those basic things really still come up in many of the hospitals, whether it is a dispensary in Kombewa or it's in Lumumba, and that whole thing of, do the facilities have what they need when they need it, or are we going for things that people don't need, and yet the basics are still missing in these facilities? That's why everybody then will rush to the referral facility.
Thank you, Joe, for that question. I want to start by saying that there are times that patients come to health facilities and they have complaints that they did not get the drug or the commodity that they were supposed to be treated with. That can happen in two circumstances. First, it could be that the particular commodity is a commodity that is outside of the essential drug list, because we do have an essential drug list which lists drugs that, let's say, 90% of our clients will need, but there might be the other 10% that may need some specialized drugs that may not be available. So in such circumstances, it is actually true that the clients may be asked to purchase this elsewhere. But there are also circumstances where there may be a true shortage of particular commodities. And I think one of these shortages sometimes have been there for a while historically in the health sector in Kenya. If you look at it, but things have been improving. If you look at it, initially, we were using the push system, when KEMSA would just bring you what they thought that you needed. Then we moved to the pull system, where we gave the health facilities the authority, the power to actually, indicate what they actually need, and then they are supplied based on what they have requested. So this pool system has been able to actually improve the availability of these essential commodities in our health facilities. But one thing I wanted to say...
So you're saying that, when you talk about push, pull, all those things, they can
Yes.
sound very complicated. So
Yes.
you're saying that right now, the medical institutions, the hospitals, dispensaries, they say this is what we need, and that is what KEMSA supplies, as opposed to KEMSA pushing, as it were, whatever they thought the hospitals needed. I just wanted to get that correctly.
Exactly. When we talk about the pool system, we ask the dispensary, the health center, tell us what you need. If it is amoxil, what quantity do you need to cover you for 3 months? So they actually do it, and they tell us, they quantify what they need.
Okay, okay. Esther, let's get a basic perspective here. I mean, you focus on rights. You look at health from a rights perspective. What is that sentiment that you get when you speak to people, the Wanjikos or Atienos in this part of the world, as it were, when we are talking about healthcare services, access, availability, quality, and that sort of thing?
The critical process is that communication is also important, because for us at community level, push-pull, we don't understand push-pull. Mm-hmm. When you go to a health service, a health service space, you're supposed to be able to get it at the lowest unit. So it means that one of the things for us we critically look at is that, what is the person going to get? Sometimes you don't even want a drug. You just want a service, somebody to talk to, for example. So at that lowest village unit, if you're talking about even the facilities, because health services have been devolved. So when we go to that lowest village unit, in that facility, does the person get the same sort of service that you would get at the level 5 facility? So that is the challenge which most community members have. That when you go to that health facility, maybe we don't have enough human resources for health. And maybe the human resources for health means that, one, the person who is supposed to be in that facility, do we have enough housing, adequate housing for the person who is supposed to be in that facility? And we even have, for example, if that facility is supposed to be operating 24 hours, does someone able the security to that particular place? So for a person to, for example, even here, let's say Kisumu, to move from Obunga to Jot, or the nearest health facility within that space, means that other considerations need to be taken into place for that person to access better health care. And it means that the human resources for help need to be responsive to what they declare exists in their service charters. Because if you have a service charter which says that this is the service I'm supposed to get, you're supposed to wait 10 minutes, and you go there and wait 6 hours, and you still don't get the service, then we still have the complaints and the challenges which then we see in the social media spaces, and then we do not get feedback adequately. So it means that we need to communicate better through strengthened health systems and communications to community members about why we have challenges. Even if sometimes we say that there's delays from national government coming to county governments, services still have to be delivered adequately. And those are some of the challenges that we see. So when you talk about even commodities, reproductive health is important to us, but we also will look at non-communicable diseases. So when you're looking at the issue of non-communicable diseases like cancer or diabetes, do we get those services at that level? So when you talk about are those drugs on the essential drugs list? So who knows when we're talking about non-communicable diseases, if you can't afford that at the lower unit, then it is the community member who then serves. Right to health is to everyone.
Let's come to this, Prof, and I'll come to you, Dr. in a moment. Prof, Easter raises the question of what is really essential, because we've come to a point where some of the diseases that we used to think were the most common that everybody dealt with have changed quite a bit. You yourself you have a special story about cancer that you have fought, and is this part of what is called essential? Has essential changed over time, and we perhaps are still caught up in a time warp?
Well, the issues that she's raising are very, very fundamental and very true, because, you know, part of it is not just drugs and equipment and all that. There is a human resources aspect of it. And the human resources doesn't just mean that you have bodies there standing, one is a nurse, one is a clinical officer, and so on. They must have certain attitude and certain capacity and capability to do things. And secondly, they must observe certain ethics of dealing with something like health. The problem we have had in our health system, and I've been a Minister for Medical Services, so I think I know what I'm talking about. The problem we had in our health system is that health ethics has broken down, so that a doctor, a nurse, or a clinical officer wants to behave as any other worker in an office, which is different. It's like teaching. It's a vocation, it's a calling. So my feeling is that we need some kind of continuing education for health workers so that they know what it is that to be a resource in a facility at whatever level. That's the first thing. The second thing is that who is the most important person in that health facility? It is the patient. A patient-oriented health system. I was saying something when he interrupted me. When I said that's why we brought the Cubans here, because one of the reasons why the Cuban system works is because it's a system. And the health workers are trained to take the patient as the central cog in the health system. And then the health system begins from the family. Even we in families can be a problem to the health system. If you feed your kids wrong food, you prefer processed food rather than ordinary food from the garden, you are a problem to the health system. So we must educate families to know that health begins with family behavior and family health care. So that's why I was saying, Joe, that look, these people called community health workers are very important because they are people who take care of the health system at the most primary level. And they must become part and parcel of the health system and make sure that they also act as a triage to people going in primary healthcare facilities like dispensaries. That is something that we must adopt. And one of the most important things about these pilot counties in universal healthcare is that we want to ask ourselves, if universal healthcare is going to succeed, what can we do in these pilot counties to show Kenyans that this is possible? What are the optimal conditions that we need to have in these counties for the next 1 year to see that universal healthcare can succeed? And they include that kind of things you're talking about, not just medicine, but the whole system.
And that would be very, very, very interesting to watch, because I think it will set the pace for a lot of things. Dr. Manjari, there's the question of money. at the end of the day, there is usually the bottom line of money. And one of the conversations I have seen is whether KEMSA gets paid for what it delivers. And that's a long-running conversation I'm sure you're having with counties. How is that situation right now? Because KEMSA, as I understand, runs what's a revolving fund. So when you're paid, then you're able to get more.
Yeah, I would answer that and say, Joe, that this is a cyclical issue. And counties, towards the end of the financial year, usually have what we call pending bills. And at the same time, immediately around July towards August, counties start getting a lot of money, and monies are dispersed monthly. And I can tell you that the situation by close of business 30th of June this year, KEMSA was owed around 2.3 billion by counties. The situation improved immediately, and we have what we call aging debt. So currently, over 90 days debt is 1.5 billion. But the new debts, meaning counties are ordering fresh, is around 1.2. So when you add the two, is 2.7 billion. But I'm happy to say that counties are actually entering into MOUs, signing MOUs with KEMSA, service level agreements. And we are seeing most of the counties coming and getting confidence with KEMSA and coming to buy from us. One of the biggest strengths that we have is that we deliver to the last mile, meaning it's an end-to-end solution where counties do what we call online ordering. We do, we pick from the warehouse and we dispatch to each and every doorstep of every health facility. So the issue here, as you are discussing, is we have to look at the component of universal health coverage in a bigger aspect, other than just the issues of medicine. Mm-hmm. And the issue here is affordability, quality, and actually something that is accessible. So horizontally, you have to be having access to each and every facility, and that's what KEMSA is trying to solve. Then the issue of affordability, we do what we call economy of scale. We purchase in bulk, and we get the best price of our commodities and drugs that we get at KEMSA. And when we distribute to the counties, is actually at the best price they can ever get across the
But I think it would be great to get answers from the county government, especially now that we have two people from this county. On this issue of payment, Dr. Onyango, you could defer to your boss if you want, but Kisumu County, for example, the last check was, I think, owed KEMSA 35 million. What happened? Why do counties owe KEMSA, for instance?
Well, I think that's a difficult question, but I think I want to declare that this county owes KEMSA very little money compared to maybe others from what I checked. I think progressively our debts with KEMSA have been reducing. But I think we also need to look at the financing model for counties in the concept of devolution, that counties get money from the national government, and then we are able to purchase from KEMSA. You see, if you look at the way supply of commodities before devolution was happening, KEMSA was being given an allocation, a budgetary allocation, and they were just supplying. But now we are, we are clients of KEMSA. We are their customers. So we have to be able to purchase and pay up our debts, and sometimes they want to insist that we pay up before we, But I think, with good organization, with good financial flow from the national government, I think there's a lot of commitment on the part of the county. There's
also the question of the monies, the health budgets being diverted to other things. I mean, it's a very common problem that I think many counties are dealing with, where they take the money elsewhere as opposed to what is really essential. Some people think health is really critical, and even when money is budgeted for health, it still goes into something else.
To my knowledge, I think this has really improved. I think our governor is a minister for health, and so we have got a lot of support when we actually need, because if you actually look at it, it is the reality that sectors compete. But I think we have got a lot of attention as the health sector in being able to sort out our issues. And I would say...
Easter, in your engagements, and Governor, I'm coming to you, you are not going to escape from this, but Easter...
I'm not going anywhere.
Easter, in your
I was waiting for you, actually.
In your engagements, do you track what happens? Because at the end of the day, that then affects the quality of services that come to the people, isn't it?
We do, because with different civil society organizations, we do what we're calling budget advocacy, so that then money goes not into recurrent expenditure, but also development expenditure. So when you have a huge amount of money going into recurrent expenditure, sometimes the money does not go into what we call the right places. So even, for example, if you get 30% of the budget going into health, how much of it goes, for example, into reproductive, maternal, or adolescent health care? So it means that services to those particular areas does not essentially improve because there's too much money going into recurrent expenditure. So we need to also look at the bit of how budgets are also done. So that when budgets are done, there are certain areas. Universal health care for us, it will be very important for us to talk about reproductive health. Because when we look at the adolescent HIV infections within this region, how do we invest in those particular areas? If you look at the maternal mortality within this region, how are we investing in those areas on preventive health management? So that bit is what we hope for us, that's what we advocate for, that there must be money going into areas where people are feeling it. Instead of probably a number of times you see malaria, for example, or the money goes into TB, for example, yet we have many young mothers who might not be able to access great health care. So changing that conversation so that we engender the whole process of health care is for us very important.
Professor, ring fencing, would it help, and why are you not paying KEMSA, for example, as counties?
As far as Kisumu County is concerned, when we came into office, obviously there was a lot of big pending bills in this county. But we decided to analyze these pending bills, pending bills which were just lies, people just cheating, pending bills which were doubtful, and genuine pending bills. It so happens that KEMSA's pending bills were genuine, so we paid it.
But the last time I checked, I think you still owed them 35 million.
35, by the way, 35 million in terms of health bills is very little. It's
I can make a comment on that.
Yeah, because, and secondly, one of the reasons why counties...
Okay, I will come to you, but
one of the reasons why counties lag behind sometimes in paying bills is because Treasury does not give the money in time. Treasury delays. Exchequer releases delay. So if you don't have the exchequer release, you have no money to pay, but you need the medicine anyway. So you'll get the medicine and tell KEMSA, I'll pay you when I get money from the Treasury. When you get money in the Treasury, if you are honest, you'll pay. If you're not honest, you don't pay. And we have to be honest, because counties are not the same. There are counties which will decide to divert the money to other things. That's also a reality. So my sister there is right. Secondly, by the way, Joe, the health sector, having been a minister in this area, is a very difficult sector. Why? There are too many people involved in financing the health sector. Global Fund, I don't know what, Linda Mama, whatnot. There's so many things in the health sector. For a government, a county government to juggle with these and to know exactly who is paying what and for what and where the money I get from the Treasury, how should I use it most productively, it's not an easy thing. In fact, today we had a meeting at Pan-African Hotel on this USC with CS Cicely Kariuki. These are some of the things we're discussing. In the morning, we were discussing Global Fund at the Council of Governors. In the afternoon, we are discussing UHC. Global Fund is a fund on its own that funds HIV, AIDS, and TB, isn't it? Yeah. And malaria. And that one you cannot touch. It funds those things according to terms that they have set. So when you get Global Fund, go to HIV, AIDS, go to TB, go to malaria. So when you get money from Treasury, you know that malaria, TB, and so on, and HIV have been taken care by a Global Fund. Then you ask yourself, is that fund adequate to deal with those issues? If it's not adequate, then you have to take some money from the Treasury and supplement it. What is the moral of the story? The moral of the story is the following. One of the reasons why we have decided to implement universal health care is finally to answer the question, how much resources do you need to provide Kenyans with access to affordable and quality health care as prescribed in Article 43 of the Constitution? How much resources do you need? To tell you the truth, Joe, the answer to that question is not yet known until we finish the pilot of the 4 counties. That's why they're called pilot. So if you press me and ask me how much money do you actually need to do all the things that the lady is asking you, I would say, I don't know. Although I was Minister for Medical Services for 5 years, I still don't know.
Wow, wow. Dr. Manjari, you wanted to say something.
Yeah,
when
I want to first
when the governor was trying to
thank the governor for being one of the most progressive governors in this region and in the country. Having said that, it's good to say the truth.
I hope you're not saying that because you're in his county.
No.
Sort you out when you leave this.
It's good to say the truth.
Okay.
Is that the Kisumu debt can be divided into 2. Is over 90 days, which is 35 million. And recently, we brought them commodities worth 21 million, which shows a lot of goodwill. And the reason I'm saying the governor is very progressive is that we have sat with his minister, and we have had conversations with the finance minister, and they have agreed going forward they'll be paying. That thing I want to say is that today, during the meeting, we were very fortunate that all the governors of the 4 counties agreed to ring-fence money and protect that money to be managed by KEMSA through the Minister of Health. And I want to assure you, there is no patient in Kisumu, Isiolo, Machakos, and Nyeri that will lack any medical commodities. The other thing I want to say is that we have program commodities, and that is TB and a global fund, and malaria and a global fund. And also we have HIV commodities that come through USAID. They have a lot of confidence with KEMSA, and we are actually procuring for them. And all what we do is that we charge them money for warehousing, procurement, and distribution. So we are all set to go, and we are ready when this thing is rolled out.
Prof, I know that when you were Medical Services Minister about 10 years ago, you disbanded the board of KEMSA. At that time, it was Kenya Medical Supplies Agency. Among other things, you said it was inefficient and all of those things. Where are we now, in your view?
It was in total chaos. I mean, the board was, the chairman was fighting the CEO was fighting the chair, the board was trading with KEMSA. So it was an incestuous relationship, which could not be sustainable. In fact, I'll tell you a story. The day I went to Afia House for the first time as a minister, I was shocked the number of people who were in the corridors with Vilembe and all these things. So I called my PS, Ezron Nyagitu, the late. I said, come to my office. He came. I said, what are all these people in the corridor? He told me these are service providers. The first time I heard of the word service providers, I saw service providers found in bars. But anyway, then I said, what service are they providing? He said they're providing pharmaceuticals. I said, why are they here? They should be in KEMSA. I said, no, our people have been buying these things. I said, medicine should not be bought in the ministry, it should be bought in KEMSA. Then he told me KEMSA is being functional. Then I said, make it functional. So when I called KEMSA management and board to the boardroom 3 days later, I saw what Nyagitu was talking about. So I decided to disband the board of KEMSA and send the CEO on leave and appoint a caretaker committee to write a new law for managing KEMSA, and that's why these people are here now.
Okay, and it's befitting that we are starting this conversation in your county. Yeah. And we're going to involve the audience a little bit now, and we'll do more after the break. But first of all, let me go to my colleague, Mashirima Kapombe. What do you have, Mashirima?
Yes, Joe, as we talk about service providers, there is also the question of legitimacy of the drugs in the market. And Mustafa Musa has a question on that.
Thank you. Thank you. Actually having a healthy talk. My concern was about procurement. After the procurement, and we get actually the drugs that are not liable to be given to the patient, counterfeit. So the ones who are going to for the procurement of these drugs, and then the counterfeit of these drugs, I wanted to ask actually the CEO of the KEMSA, is there forensic for this procurement, and how do you check the counterfeit? Thank you.
Yeah, you can answer that, then we take a break.
Yeah, thank you. I want to confirm that KEMSA has a very rigorous quality control and quality assurance process, and the issue that all the products that we do procure and dispense and distribute to the counties are actually good, of high standard products. The counterfeit aspect is something that is supposed to be checked by the Pharmacy and Poisons Board, which is the one mandated to do surveillance. And they have actually, we have what we call pharmacovigilance, we have drug inspectors, and they go to each and every facility. And that's why recently you've been hearing pharmacies have been closed, chemists have been closed by Pharmacy and Poisons Board together with Medical Practitioners and Dentists Board. So this is not a KEMSA issue. This is another body that should be doing surveillance. But sometimes when you hear that our products have an issue, we usually send a team which goes to the areas where that has been done. We do quarantine, and we pick those commodities and we take them back to the quality assurance lab, and we authenticate through the batch numbers, because we have barcodes and batch numbers, and we track them down all the way to the consumer. So issues of counterfeiting from KEMSA, that is not something that is there.
All right. Thank you very much. You are watching the inaugural edition of Monday Special Town Hall, coming to you live from Kisumu County.